All right. Today I'm going to be talking about mechanical ventilation in critically ill patients and the role that respiratory therapy plays in improving patient outcomes. This is an important topic because mechanical ventilation is used every day in hospitals, especially in emergency departments and intensive care units. And how it's managed can have a direct effect on whether or not a patient recovers or even possibly develops other complications. I also feel this is important because a lot of the time these are emergency situations. Some of these people and their families have never even heard of mechanical ventilation until they find themselves or even a loved one hooked up to a ventilator. I can only assume how scary this is. You could be awake and fine 1 second and wake up days, even weeks later, hooked up to a machine that's breathing for you. And these machines, they're not necessarily always gentle. They're using pressure and pretty much can be forcing volume into your lungs. So you can only imagine how uncomfortable that would be. So, what is mechanical ventilation? Mechanical ventilation is basically a machine that helps patients breathe when they're unable to do it on their own. It works by delivering oxygen to the lungs, and like I said, they either do that using pressure or even volumes, just forcing volumes into the lungs. It's commonly used in, as I said, critical care settings like the ICU or emergency departments for patients who are in serious shape. If a patient isn't ventilating, that means they're not releasing carbon dioxide, which is a byproduct of you breathing in oxygen. And when you breathe in oxygen, you need to blow out carbon dioxide. And a buildup of this can lead to a plethora of symptoms, and the most severe are normally like coma, loss of consciousness, seizures, and paranoia. A lot of the times, as a respiratory therapist student, you see a lot of COPD patients, and COPD patients are known to retain carbon dioxide. And a lot of the times you see them have kind of like tremors or shakes, and that's because they have a buildup of carbon dioxide. So, why exactly does mechanical ventilation matter? There's several reasons a patient might need mechanical ventilation, and some of the most common conditions are acute respiratory distress syndrome, which is also called ARDS, uh, pneumonia, trauma like motor vehicle accidents, drug overdoses, and complications after surgery. In these situations, patients may not be able to get enough oxygen or remove carbon dioxide, or oftentimes even protect their own airway, meaning they can't cough, they can't swallow. So, as I'm sure everyone remembers with COVID, it was actually a pretty common reason to end up on a ventilator, and usually in older people. But COVID definitely put respiratory therapy in the spotlight. Not many people were even familiar with RTs until the pandemic due to the sheer number of people who ended up needing mechanical ventilators. So, unfortunately, even though mechanical ventilation is a life saving intervention, it's not a benign therapy. Some complications include ventilator-induced lung injury, pneumonia, and yes, you can get put on a vent for pneumonia, but a vent can also cause pneumonia. You can also get delirium from excessive sedation and muscle weakness because you're laying in a bed this whole time. You can't get up, you can't move, so that can definitely have an effect on your body. But that's why proper management of the ventilator is so important because poor settings or delayed adjustments can actually worsen the patient's condition. And that's why respiratory therapist monitoring is so important. Too much volume or pressure in the lungs can actually reverse what you're wanting to do. You can cause injuries, but on the other hand, too little volume or too little pressures can cause pneumonia. So you kind of gotta balance those two things out. So one way to balance these things out is taking into account lung protective ventilation. And this has been one of the biggest findings in research since over the last couple decades is the importance of lung protective ventilation. It involves using lower tidal volumes, which basically means delivering smaller breaths to reduce stress on the lungs. Studies show that this approach actually reduced mortality in patients, especially those with ARDS. So instead of giving more air, we learned that giving less air in a controlled way is actually the safer route and the safer way to go. Since I explained tidal volume, I'll go ahead and explain permissive hypercapnia. As I mentioned earlier, that when the body is unable to get rid of CO2, it can cause some pretty serious symptoms, and increasing tidal volumes is usually the best way to get a patient to release that CO2. But in the case of ARDS, using high tidal volumes can actually increase mortality rates. So, since low tidal volumes are needed, ARDS patients are actually allowed to have slightly higher CO2 levels in the blood, which is interesting because CO2, we're taught that CO2 is harmful, and too high of a CO2 count can actually have negative effects. But with lung protective ventilation, you can actually allow them to have those and have hypercapnia. So now we get to what exactly is the role of the respiratory therapist. I've told you about mechanical ventilation, but what do the respiratory therapists do? So they play a major role in managing mechanical ventilation. They're responsible for setting up the ventilator, troubleshooting, adjusting settings, monitoring waveforms, which can show pressure over time, volume over time, the amount of pressure needed to give a volume, and vice versa, and drawing blood gases. So RTs, they're usually the first to notice changes in the patient's condition, just because they're always with the patient, they're always at bedside, and they're constantly studying what exactly each patient needs. Because not every patient's the same. One patient may need excessive pressures, one patient may need excessive volumes. It's just kind of come up with it as you go. Now that we discussed the ventilator itself and the role of the therapist, let's discuss the patient. So we're going to cover dyspnea. So this is something often overlooked in the patient's experience while on a ventilator. Even if their oxygen levels look normal, patients can still feel like they can't breathe, which is called dyspnea or air hunger. This can cause anxiety, panic, and as you can imagine, long-term psychological effects. Since patients are unable to speak due to the breathing tube, this distress can sometimes go unnoticed. So usually patients are so sedated they can't communicate at all, or they even have trouble. Sometimes if they're awake enough, you can have them write down what they want, or get. What I've seen a lot is there's these little sheets that will have like keywords on it, like hungry, or I'm tired, or I want to go home. And so if they're awake enough and not under too much sedation, normally you can just have them point at what they want, which I think is a pretty sweet tool. So now we're going to cover emergency department ventilation. So mechanical ventilation often begins in the emergency department and ICU, just because that's where all the emergencies go. So research shows there is a lot of variability in how ventilators are managed in the emergency department. This is important because the first few hours of ventilation can have a huge impact on the patient's later outcomes. Starting proper ventilatory settings early can help prevent complications. And during initial setup, in order to calculate how big of a breath we need to deliver, we use an equation called ideal or predicted body weight. This is important because if someone's 600 pounds, their actual body weight doesn't reflect the size of their lungs. Lung size is determined by height and gender, not body fat. So if we were to base the tidal volume off actual weight, we would deliver such large breaths that we would actually cause a lung injury. And that just goes back to what I was saying about proper ventilatory settings. And as I mentioned earlier, not every person's the same. You got to do a little bit of math and just kind of trial and error as you go. So now we get to a little bit of, I guess you could say, a brighter side, something not as sad and depressing. Eventually, the goal is to remove the patient from the ventilator. This process is called weaning or vent liberating. One common method used is called a spontaneous breathing trial. And essentially, they're reducing the support that's been needed by the patient so they can breathe on their own. So essentially, you're taking those away and seeing how they do. Sometimes patients freak out and can only last 5 to 10 minutes or maybe half an hour. And other times they do a little better and can go for hours and hours. And once they get to that point, they'll be liberated from the vent. Respiratory therapists are heavily involved in this process, and a successful weaning can reduce long-term complications and shorten hospital stays, which is not only good for the patient, but it's also good for their wallet and their bank account. All right, so some of the key takeaways. Overall, mechanical ventilation is a critical part of modern healthcare, and it saves many lives. However, it's not just about using the machine. It's about how it's managed, lung protective strategies, early intervention, and continuous monitoring. Respiratory therapists play a huge role in this process, and patient-centered care is just as important as the numbers we see on the monitor. And a lot of people think, well, you have a machine doing this for you, but no, it takes a lot of math, a lot of critical thinking, a lot of talking with the other disciplines. You always want to keep your nurses involved and your physicians involved, and it's a mechanical ventilation is a pretty important thing. It's, like I said, it's not just a machine. So I hope no one has to experience this, but it's always better. It's always better to be aware and kind of know what to expect.